grateful to him for allowing us to hold this webinar here for the benefit of our students. And we would like to thank him for the same. I would request Dr. Rajesh Sinha, who is the Treasurer of All India Ophthalmological Society, to please felicitate him with a bouquet. And I would just request him to say a few words.
I think it's a very touching moment when the AIOS for the first time is holding an international webinar, and all credit goes to Professor Namrata Sharma and Professor Rajesh Sinha for having conceived this idea and has brought it into being, and that with the help of Johnson & Johnson, they have been able to get this program going, and we have none other than Dr. Jeevan Singh Titiyal, who is a world authority on good phacoemulsification, good practices of phacoemulsification and refractive surgery, especially SMILE, for which he's written a book. And I think no better person than him to give a very good overview on use of and improving the outcomes of premium IOLs. And I'm very proud that this webinar, the AIOS is Dr. Namrata Sharma and Dr. Rajesh Sinha are holding it in the RP Center, and it's a matter of pride for us. Thank you very much.
Thank you so much. It is my privilege and honor to introduce the speaker to you, Professor Jeevan Singh Titiyal, who's a Padma Shri. He's Professor and Head of Cornea, Cataract and Refractive Surgery Services and Chairman of the National Eye Bank. He has over 200 international publications in the peer-reviewed journals, has 2 books to his credit, and one of them has come out very recently on SMILE. He has numerous presentations. He was the first surgeon to do live surgery at ASCRS in USA from India. He has conducted several instruction courses at international platforms such as American Academy of Ophthalmology, ASCRS, ESCRS, APO, APCRS, etc. He has numerous awards to his credits, which include the Achievement Award by the American Academy of Ophthalmology, by Asia Pacific Academy of Ophthalmology, and the Educator Award by the Asia Pacific Academy of Cataract and Refractive Surgery. It is a very proud moment for us, and thank you, sir, for being here. And above all, he's a great teacher and mentor, and personally and professionally a huge support for both of us, me and Rajesh. And he would be talking to us on enhancing outcomes with premium intraocular lenses, extended range of vision intraocular lenses.
Thank you, Professor Namrata and Professor Rajesh, for inviting me for this, I would say, a prestigious webinar of AIOS, and getting me into a spot where I am the first person to do a international webinar from India. And also thankful to Chief RP Center for allowing us to be in RP Center. It's a great pride for me to be sitting on this dais and talking something to my students and colleagues and friends of my country and other country also. And looking into the cataract surgery and its outcome, we all know that intraocular lenses has changed the entire scenario of visual outcomes, the quality of vision, quality of life in our patients across the world. And today, talking on how to enhance the outcome of these premium IOLs, and especially looking for extended range of vision IOLs, will be a great session for all of us. And I welcome you all for this webinar, and looking forward to interaction with you with your suggestions, questions, which can be brought forward during my presentation. I have no financial disclosure to be done for this particular webinar. If you look into my entire session, which will last for 1 hour, will include basically how cataract surgery evolved in past, and with the intraocular lenses scenario, and something on monofocal and premium IOLs, and looking for a preoperative evaluation of all cases, the proper selection of cases for multifocal IOLs, intraoperative considerations, and I would be very happy to look into a post-op assessment and problem solving, which are the key factor for success in any IOL surgery including the premium IOLs also. And towards the end, I'd like to share our experiences with these premium IOLs, especially on extended range vision of IOLs, which has been a new category of correction of vision in cataract surgery patient for us. Modern day cataract surgery, we all know, has evolved from the basic extracapsular, then shifted to intracapsular surgery, then extracapsular, then we have phaco, and now we have a femtosecond assisted laser cataract surgeries. So you can see there has been a wide shift in a concept of cataract surgery, and mainly because two things. One was to achieve the better visual outcome, which happened because of IOLs. And IOLs also changed from a rigid lens to foldable lenses, which basically gave us the idea of getting a smaller and smaller incisions to decrease the induced astigmatism in our patients and get an early rehabilitation. And this also compounded the fact that patient had a wider expectations of these surgeries. They looked for a 20-20-20 vision for all ranges and improving the contrast, improving the vision for myopic conditions and photopic conditions, and having a better binocularity and stereo acuity for these patients. The challenge is not only for surgeons, challenge is for the product which we're going to use, the surgery which we do, and the outcome patient is going to receive for us. As I said in the beginning, 1949 was the day where intraocular lens came into human practice. And subsequently, we shifted to a foldable IOLs and present day era. And looking into monofocal IOLs, we know what changes has happened. In premium IOLs, I would consider one of the first one to be considered was multifocal IOLs. Then we had a toric IOLs, which also changed the concept, accommodative IOLs in between. In multifocal, we had a bifocals. Now we have trifocals and extended range of vision of IOLs. So this is a huge category of lenses. Monofocal lenses, I would say, is still the most commonly used lenses for a cataract surgery across the world because of various advantages of monofocal lenses. It has now a square edge design to decrease the PCO or after cataract visual axis opacification with these IOL surgeries. We have modified the surface, both anterior posterior, to decrease the posterior capsular problems, as well as making the biocompatible material. Then you have a UV absorbing material, and looking for two important things. One is the uveal compatibility and capsular compatibility. These thoughts have come into us in the past. One of the major things which has happened in IOL surgery was because you are leaving the posterior capsule behind, and that ultimately gets fibrosed, or the cells from a peripheral area migrate to central area to cause visual axis opacification in these cases. The first time the concept of square edge design came to block the peripheral cell to migrate to center and decrease the incidence of PCO happening in your patient in the early phase of post-cataract surgery in these cases. Then second shift, major advantage came in our IOL design were aspheric designs to counteract the spherical aberration in these patients. And that was also very, very significant change because this enhanced the visual quality of patient by improving the contrast sensitivity of these patients. So you have various models with different types of asphericity, and they can be customized for patient to patient depending on how much is a positive spherical aberration of cornea in these patients. Then in IOL materials, we have PMMA lenses, then you have silicone lenses, hydrophilic lenses. All these lenses had a higher incidence of PCO, and YAG capsulotomy rate was much higher. Subsequently, we had a hydrophobic acrylic IOLs, which has better capsular compatibility. Therefore, addition of posterior capsule toward the posterior surface IOL was much better, and that decreased the incidence of PCO formation in these cases. Two major things happened in the IOL material in past. One was the discoloration of these lenses, which are very common with silicone lenses, and opacification lenses, which also was very common with hydrophilic lenses. So these two materials had gone into past. Now we are looking for a hydrophobic acrylic materials. Let me come to the premium IOLs. Why there's a need of these lenses? Why should we look for a premium lenses for our patients? Would they have an advantage? Yes, they have an advantage of correcting astigmatism, because residual refractive error, especially the astigmatism, is a major cause of patients' dissatisfaction in a post-op period. If that is tackled, then you have a better outcome for your patients. And we are looking for something which we all desire, spectacle independence for subsequently after surgery. Surgery is such a psychological word where patient feel after surgery everything should be corrected to as normal as possible, which is normally not possible. But yes, one surgery, that is cataract surgery, where patient's expectation can be met to improve their quality of vision and life. Looking into a quality of vision, you would say this is a monofocal lens which will give you a one distance correction, mainly for a sharper far vision for these patients. You can see a very clear, you can see the HUD there. But if you look at multifocality, then you have to see everything. You're driving a car, you have to see the dashboard, you have to see the mobile phones, you have to see the distance. That is where the multifocality is required. Or natural eyes are meant for a multifocality. So that has to be replaced by whatever we do subsequently after cataract surgery in these patients. How did this multifocal came started in 1980s? As I told you, the first bifocal lens was a PMMA lens, which required a more than 7.5 millimeter incision, and that access had a huge astigmatic induction into surgery. Subsequently, we had a silicone lenses and hydrophilic lenses. Then we had a hydrophobic lenses. But design-wise, mainly they were refractive lenses and they were diffractive type of lenses. Both have their own problems in terms of improving the vision, then subsequently having a symptom which a patient may not be able to tolerate subsequently. Refractive designs of multifocal, we have multiple concentric zones with different curvatures for near and distance. Therefore, they have a different focus for a distance and near, which is going to be creating problems, and they are mainly pupil dependent. And once you have pupil dependent lenses, they are difficult to tolerate as such. And diffractive multifocal, again, you have a concentric rings across the entire surface, right from the center to periphery. Each ring has a discrete border, creating a diffractive patterns for a light which is passing through, and always creates a two focal points. And the split of the light which is passing through is split into a distance and near. Therefore, the contrast goes down significantly in these cases, and the visual quality may not be as good. So they have a limitation, both refractive and diffractive. So you have other types of lenses which are partially diffractive multifocal IOLs, and their diffractive pattern covers only the specific area of optic. So you have an optic which is meant for a multifocality, then you have an optic for a monofocal refraction. That is how you decrease the pupil dependency, and the glare and halos can also decrease in such cases, but they still persist as the advantage of mesopic and photopic conditions. The lens provides more light because you have a lesser division of concentric areas. So if you look into a present day IOL, this is how we classify these IOLs. Bifocal lenses no longer being as advantageous for us. We don't prefer these lenses now, though we have a categories. In one of the most popularly used bifocal lenses will be Acrisoft from Alcon group of lenses. You have a Technis. They range from a +4 to +2.5. Then you have a trifocal lenses, which are in practice now. Then you have an extended range of vision, which I'm going to talk about subsequently. And you have a new technology for a trifocal lenses with the enlightened technology, Panoptics from Alcon. So this was the scenario of a huge range of IOLs you have for your patients. Who's going to decide which IOL to be put? That will depend on a subsequent discussion of mine. The first thing would come how we assess your patients for a cataract surgery per se. Then how do we look for these patients for suitability of different IOLs? So if you look for multifocal IOLs, I think patient selection, accurate biometry, which is important for all cataract surgery, but it is much more accurately should be done for a multifocal lenses or a premium IOLs than getting a surgery which is as appropriate for a good fixation of IOL in the bag in your cases. The profile of patient gives you a lot of clue for selecting your patient for multifocal or a premium IOLs. If you're a patient who comes with a lot of knowledge of IOLs and multifocal IOLs, he has a lot of queries for you, how this will happen, would this give this problem, or how many rings are there. So these patients are going to create problem for you. These patients are actually too much motivated for a particular type of IOLs. So demotivating these patients are difficult, suppose they are not suitable for multifocal from your side. So these patients, you have to be a little careful, more chair time is required for these patients. So you have a patient who has a knowledge for IOL but doesn't know about multifocality, or they have a few queries for multifocality. these patients can be counseled nicely to get acceptance for a multifocal IOL, and their questions can be answered subsequently. But looking into a scenario in our country, many patients will come without a knowledge of even a cataract surgery, type of surgery, or IOLs. So these patients can be motivated for any type of IOLs, and they are also much more suitable candidate for a multifocal IOLs also. There are two things are very important subsequently. Once you have a patient, you have to look for two areas of patient's profile. One is the profession of the patient. Second is how much patient expectation is there to look into what would be the outcome of cataract surgery for these patients. Profession-wise, very demanding profession like drivers, especially night drivers, engine drivers, pilots, may not be suitable cases of multifocal IOLs. These patients may be best suited for aspheric monofocal lenses because they want to have a best possible distance, sharper vision for their work conditions. Retired people, elderly people who have not very active life may be a suited case of multifocal IOLs as such. Then you have a demanding profession like us, like surgeons, who require a multifocality, but also require a very sharp focus for an area of their concern. Again, there I would suggest monofocal lenses will be better choice, and multifocal lenses can be a secondary option for these patients. Then in terms of, as I said in the beginning, patients profile-wise, how much is the patient's expectations? Patient who demand less, maybe a better choice for us for giving any type of lenses, including multifocal. Patient who desires a perfection may not be a good candidate for multifocal IOLs as such. But all these category patients may be suitable for any type of IOLs if they have been counseled properly and they understand the outcome of your surgery and the intraocular lenses to be put in these cases. Now, I would say no patient would be not suitable for a multifocal IOLs if they are physically or anatomically not suitable. That's a different thing. Otherwise, they can also be motivated for multifocal IOLs. Ask questions of their expectations, like a free spectacle life, what type of work they are doing, near work, distance work, or intermediate work like a sitting in an office with a computer or laptops. That will make important judgment for you. One thing is important here while assessing the patient, the astigmatism part has to be looked into, because these residual astigmatism in your cases will be the most difficult task to explain to the patient subsequently after your surgery. Other important thing which sometimes miss out in cataract patient is assessing the ocular surface, because there are many patients who have a very poor ocular surface. So this affects the right from the initial judgment of your biometry to ultimate outcome of your patients. If your tear film is not proper, your keratometry or a topography will not be appropriate, and you have a wrong calculation of your patients. So make sure your ocular surface is proper before you look at topography of your patients. Similarly, in the post-op period, your tear film is not appropriate, then you're going to have again a problem for these patients. So tear film ocular surface is very important and very key for a success in your premium IOL practice. Then looking for cataract also, sometimes posterior subcapsular cataract, will be happy to have anything. But if you have a nuclear cataract, myopic patients may not be very happy candidate for multifocal IOLs. In that regard, hypometropes will have a better chance for a better acceptance for whatever solution we give to them. Diabetic macular edema, patient with advanced glaucoma, optic neuropathies, you may avoid multifocal lenses there, because the contrast will assessably poor for these patients, and you're compounding with the lens which is going to decrease the contrast for your patients also. Anisometropia, high myopia, amblyopia may not be a suitable candidate for multifocal IOL. These are category of patients. Then, as I said, posterior polar cataract, where you have a chances of surgical intra problems, you may have to motivate patient for changing your surgical technique or a lens implantation on the table also. So that point has to be really made clear to the patient when you're counseling them, and always make sure that what is the position of other eye. Sometimes you have a very telltale sign in the other eye, because other eye may have a bullous keratopathy, may have a very poor pseudophakia, AC IOLs. So these patients will give you, this patient will have difficult surgery as such. Previous refractive surgery is another important point for all multifocal IOLs. This is because I'm saying because of two factors. Because these people have undergone refractive surgery to achieve independence from glasses. And when they come for cataract surgery, they again want the independence of glasses for all distances. And we all know the calculation of IOL power access is very difficult in post-refractive surgery patients. So you have a multiple factors which can give you a headache subsequently after you do surgery for these patients. So very carefully you have to assess your patient, take a proper history to rule out previous refractive surgery of patients. Sometimes you may not be able to pick up a patient who has not undergone PRK. So these patients have to have a good topography and wavefront analysis for these patients. And always a challenge for us to satisfy the expectations of post-refractive surgery patients. Biometry, I discussed, we need to have a very good biometry. I would say if you can capture your axial length with the optical biometer, nothing better than that. If you have a cataract which doesn't allow the optical biometry, where you have to use other devices, then immersion biometry should be the best option to the optical biometry. But if you have a variable readings in biometry, maybe this patient is not suitable for multifocal IOLs. But there, if you have access to aura, then you can again calculate the power on the table and have a best IOL power for your patient. And precision in both biometry in terms of axial length and topographic keratometry is critical for a success for your patients. Patients with multiple readings of keratometry, look for any tear film problems, then wait for some time, make the tear film stable, then take a reading. Never do a investigation before you do a keratometry. The first investigation is to do a keratometry for your patient, so you have a profile which is absolutely virgin as far as the cornea is concerned. Let me give an example of one of our biometry or axial length of one of our patients. This is the IOL Master 500. You can see here a patient has a reading where we'll be choosing, if I take 24.5 equals minus 2.1, this is the first myopic. And if I other eye, you can see if I choose 24.5, 0.25 diopters. So aiming for slight myopia is always advantageous, because if you err towards a hyperopia, the results of these premium IOLs can be worse than what we think. Little myopic shift gives a better visual acuity for distance, also does not compromise your near acuity also. So first myopia is normally our choice in our patients. Again, here we'll be going for a little off than what we think. If you're looking for a micro monovision for your patients, the dominant eye will choose for a near emmetropia, and non-dominant eye will make a little myopic, so that you have advantage of both the ways in cases of multifocality. But if you're looking at monofocal lenses, then your monovision has to be little more. There we aim for a -1 or -1.5 in those cases. Here we are aiming for a just -0.3 or 0.4 in these cases, which gives an advantage of intermediate vision for your patients. Similarly, this patient has a huge astigmatism. You can see 1.95 diopter here and 1.51 diopter here. So this is a case where surgically maybe we cannot correct this astigmatism by doing a keratotomies. These patients would require a multifocal toric lenses. The toric lenses has to be separately looked into for these patients. Otherwise, if you don't have access to toric lenses in multifocal designs, then go for a simple monofocal lenses and try to have a lesser astigmatism after your surgery by modulating your incisions in these cases. We talked about selecting the first myopic in your patient. We talked about micro monovision. We talked about looking for a dominant eye of patients. And then some cases where you're looking for a premium IOLs, is always better to do a wavefront analysis for your patients. Look for a angle alpha, look for a higher order aberrations, which can be corneal, which can be internal. That means total higher order aberration has to be looked into. Any patient who has a much more higher order aberration for cornea, if you see here, this is the eye trace wavefront aberrometry, the entire cornea is highly aberrated. So this patient is not suitable for multifocal IOLs. So this is a good scenario. If you have a cornea which is normal, whichever lens you're going to implant, patient is going to be happy. That means the aberration was induced by, internal aberration induced by the cataract, and that can be taken care of. Especially if you have a device which can look into angle alpha, angle kappa, which is also very significantly going to affect your results. The angle alpha, which is more than 0.5 millimeter, is not desirable case for multifocal IOLs, because your physiological centration is not going to match the centration of IOL in these cases. As you know, the lens is going to rest in the back, and that is as per the angle alpha in these cases. So large angle alpha and angle kappa should be a relative contraindication for your patient for a multifocal IOLs. Then astigmatism, if you're less than 1 diopter, you can still consider. If you're more than 1 diopter, then you have to look for other associated features. Like you can think of simply toric lenses or a toric combination if you have more than 1 diopter cylinder, which may not be absolutely corrected by your incisional modulation for your patients. So if there's a patient who has a less than 1 diopter cyl, I might do a keratotomy in that patient, or combine with the opposite clear corneal incision by working a steeper axis, or you look for a toric IOLs. Sometimes the steeper axis is in such an odd situation where you can't do a surgery through that. In those situations, toric IOL or a multifocal toric should be a choice for your patients. This is a simple picture which tells you how to identify the dominant eye. If that can be picked up, and this is very important for all type of cataract surgery, in fact all type of refractive surgery, the dominant eye has to be assessed. And we know that dominant eye will always be better in terms of quality and the function of patient. And they always compare 2 eyes, and then we have to really tell them your dominant eye was this, that's why you're seeing better. So if I'm looking for a micro monovision or a monovision situation, the dominant eye has to be corrected for distance, and non-dominant eye to be corrected for a near in these cases. So this is again another patient where you can see a biometry, again looking for micro monovision. Left eye is dominant, therefore we have gone for emotropia, and left eye is going to be for distance, and right eye, which is non-dominant eye, we are going to correct for near, which will be a slightly towards a myopic side, which is 0.73 diopters. So that's a good difference in a multifocal IOLs to give a better depth of perception in your patients. Then these are multifocal designs. We look into if you look into this is a Technics multifocals. They started a +4 diopter. +4 diopter is going to give you a very nice near vision. A patient who wants to read a newspaper every day, and this is the best lens for that particular patient. A patient who requires a little distance, like sitting in a computer or doing a laptop, maybe 3.25 is a better correction for that particular case. A patient who wants intermediate vision, then 2.5, 2.75 will be a better choice. Similarly, in the Alcon range of lenses, similar shift has happened. I'm telling you these shifts because this is going to take you into a different category of lenses. Because each type of near ad gives you different types of working condition, and different types of profile of patient will be suited for those type of lenses. This is a trifocal lens, which also gives you a very nice trifocality. That means we'll have a distance, near, intermediate vision for these patients. And you have a 3 segments, 3 focus, and the light which is going through the lens is divided into 3 segments. So you can imagine the entire light is not going to get to one focus. So you have a division of light that is going to decrease the contrast and decrease the vision for a patient in terms of quality. Panoptics, another trifocal lens which Alcon is going to come out, which has an enlightened technology, seems to be a better option because the distance light transmission is better, and this lens has almost 88% light transmission through the refractive apparatus of the intraocular lens, which is not 100% which you see in a monofocal lenses, and 88% is a reasonably good. This is amongst the best in the trifocal category. If you look at the defocus curves of our 3 trifocal lenses, all 3 have a reasonably good range of vision in terms of near, intermediate, and distance, and they have a different peaks. So they'll have a defocus peak for a near, then they have a defocus peak for an intermediate and for distance. So this you can see here 1, 2, and 3. So they're going to divide the entire light energy in different areas, focus, and that's going to change the contrast for these patients also. We discussed micro monovision. So I'll had an entire half an hour talked on various IOLs. There is still a limitation. The first limitation is lack of true spectacle independence when you're using those monofocal lenses or using those multifocal lenses. They could never give 100% independence for glasses for your patients, especially the near intermediate in these cases. Difficulty in dim light condition, because as I said, the light is distributed into a different focus. Therefore, that never has 100% light energy to one particular focus. The dim light vision is very poor in these cases. Quality of vision is hampered by the induction of glare and halos in these patients, which is going to hamper the work profile of your patients. We look into this wavefront analysis of one of our patients who's had a multifocal lens. This patient has a totally aberrated vision. If you look into how hazy is this E letter for this patient, has an induction of a glare and halos, which is significantly more. Anything in red is not acceptable to a surgeon or a patient. Therefore, the patient has very poor quality of vision. The blur is very big, and there's a star burst, a mixed focus for a patient. So this analysis of your patient is very critical to decide how you're going to manage your patient. What would be the patient's symptom as per your analysis? Because sometimes patients tell you something but which cannot be corroborated by yourself. So these tools will give you an idea what type of aberration patient is going on, what type of quality of vision patient has. So this extended range of vision, which we are going to talk about, would this lens be able to correct all those things? Would this be a lens of choice for our patients in terms of providing the difficulties or deficiency I talked about for multifocal IOLs? Maybe yes. This looks into overcoming all the limitation which I talked about. Let me go through this, how we can look into this. So as I said, we had +4, we have +3.25, we had +2.75. The near add for these lenses kept decreasing, looking into the patient's demand for a near intermediate range of vision for these patients. But as I said, they do have a limitation of decreased contrast, poor focus. Therefore, this new lens will come to provide the extended range of vision for distance near intermediate without compromising the quality of vision for these patients. And this all happened because of few things. One was accurate design for these cases, where they had a constructive interference of light through a diffractive design. You can see the focus is going to be sharp in these cases at a desired point of action. If you look at monofocal lenses, very nice. This is a multifocal lens where you can have a splitting of image or light into multiple areas. That accurate design will give you this advantage. And the design is like any posterior chamber IOL which is in the bag. But best would be it has a achromatic refractive surface, which will correct the chromatic aberration, which is going to talk about subsequently. And this Ocular technology, which is going to extend the depth of focus for your patients, which is less pupil dependent as such. If you look into this thing, you have an elongated focus with the Symphony IOL, which has a wide range. And in terms of multifocal, you have 2 focus areas, and monofocal with a single focus in your patients. And in fact, this is one of the first IOL to be approved by FDA for our presbyopic use. Now, we do have many lenses of this type, but FDA approval is for this particular lens only. And looking into that's going to give a continuous range of vision for a distance near intermediate and should be a lens of a choice. You can see this is an FDA clinical trial where the results for uncorrected distance visual acuity, near visual acuity were remarkably quite good in these patients. Similarly, looking for a trifocal IOLs, they also have excellent near vision, but they have a compromised intermediate vision as such. This Symphony IOLs have excellent distance near and intermediate vision. I think that should be the way of looking. You can see monofocal lenses will have 100% transmission of light distribution towards a foveal point. While if you have a multifocal lenses, as I said, it will divide the light energy into a 2 focus lens. Therefore, the energy which is going is not 100%. It is less than 80%. So that is how you're going to create defocus and ultimately have a poor vision. While Symphony lens has advantage, it has a 92% light transmission to the macula, and you're going to have a best visual acuity for these patients. And that's because of Ocular technology in these cases. There's a very sharp focus in the macular areas. Glare and halos, which are another difficulty with multifocal lenses, they would persist in any design which has a multifocality. And that holds true for a Symphony IOLs also. But we are aiming for to decrease this photopic phenomena for your patients. So because of this modification, we looked into, if you look into a restored diffractive lens, they came out the apodized diffractive design that decrease the glare and halos, then decrease the number of rings. So these things are going to decrease the photoptic symptoms. But Symphony IOLs, because of its posterior achromatic diffractive technology, the glare and halos are quite less. This is a monofocal lens. You can see how sharp is the image formed in this monofocal IOL. But if you have a bifocal lens or a multifocal lens, it's going to decrease the contrast acuity. You're going to have a blur, which is going to cause a halo for your patients. Ultimate outcome will be a starburst or glare for your patients. While Symphony IOS, as I discussed, with technology change, they're going to have a single focus there. The halos will decrease because we don't have two distinct foci here. You have an elongated foci, and that gives you a very good contrast, decrease the halos in your patients. Then in looking into incidence of photopic symptoms, this is a FDA study. They can say that patients have no halos in almost 83% of the cases. Similarly, if you look into trifocal lenses and extended vision compare, extended vision does better than a trifocal lens in these categories. And this is a Chromatic Technology proprietary for a Symphony IOL designs, which is going to improve the contrast sensitivity for these patients. And once you have an achromatic aberration, the light is going to dissociate into multiple colors, and you have a different foci. You know that green, yellow, and red is going to focus on different areas. Once this is corrected, your focus is going to be more uniform, and the vision will be far better in these cases. And defocus curve I talked about earlier for the trifocal lenses. If you look into the defocus curve of Symphony extended range of vision and compare that with the Technics IOLs, monofocal IOLs, you can see the wide range of flat defocus curve, which ranges from 1.0 to 1 up to 2 diopter, 2.5 diopters. So going to give a huge range of a good visual acuity, which is 20/20, from a 33 centimeter to a 66 centimeter. So which is a range we require for these IOLs. Then you have a tolerance to astigmatism. This is another talking point for all multifocal lenses. People talk about this. As I said in the beginning, one of the major source of a poor outcome is a residual astigmatism. The lens which can tolerate astigmatism will be the best lens. And this because we don't have a single focal point, you have an elongated focus. You can see the toric blur, it decreases in these lenses. So that is going to be a lens for most patients who have around 0.5 to 1 diopter cylinder for your patients. Intraoperatively, I think there are two things are important. As a surgeon, I always look for a best surgery possible for your patients. Looking for an incision which doesn't induce astigmatism. That means the surgical induced astigmatism should be minimal, and look for a capsular axis which is central and circular, so that your lens placement is in the back perfectly. Your effective lens position also will change if your axis is not proper in these cases. Ultimately, lens should be centered in your optical axis. When you are doing a surgery under topical anesthesia, ask the patient look to a coaxial light and get the center ring into the middle of this coaxial light will be a most centered lens for your cases. Just to briefly show one video. You can see this is a patient where I'm doing a capsular axis. You can do by any technique. The aim is to have a good circular central capsular axis. That can be achieved by a manual method like you can see here. You can do with a micro forceps. You can get it done with a femtosecond laser, or you can get it done by Jepto or any other device. But the idea is to get a good, nice central capsular axis for your patients. This is important because this is going to safeguard your entire surgery. The aim is to have a good implantation IOL. The surgery should be as effectively done as possible to decrease the damage to the endothelium or posterior capsule. After you complete the surgery, the thing should be set, the patient should be comfortable. Aspirate the cortex 100%, and subsequently you can implant the IOL. You can see that cortex is being removed now. Subsequently, the bag which is filled with the viscoelastic, you can see a very nicely centered capsular axis for this patient. The lens is being implanted, which can be implanted through a 2.2 incision, wound assisted, and very easily it can be implanted here. In any premium IOL, make sure your incision is well placed. Remove your viscoelastic entirely from the anterior chamber, from behind the IOL, and from the above the IOL also, so that your lens is properly fixed in the bag. And as I said, it is important to remove the viscoelastic because sometimes viscoelastic will shift your lens position. So this is not only important for toric, also important for all multifocal lenses like ERV. You can see my 3 dots, there's a coaxial light is right in the center of a middle of a ring. So that is what I normally do for all multifocal IOL or a extended range of vision IOLs, which is the tip I think people should consider. Other important thing here would be if you have a patient which you have worked up in the beginning, you know how much is the angle alpha, angle kappa, and that can also be looked into for the patient. Your lens can be centered as per the angle kappa if possible. Though I personally don't believe into that modification, because lens is going to rest in the bag. Whatever position you shift ultimately goes and centers in the bag. So this is the one way of avoiding too much of decentration of your patients. Because these lenses, they have a rings, and they also have aspheric design. And both asphericity and these rings, if they are decentered, the quality of vision goes down subsequently in these group of patients. Then few important things, after you do surgery, the very important thing to consider, all your patient you're going to see post-op, and once you see patient happy with your distant uncorrected vision, intermediate, near, and you get really a good feeling next day, a patient is also very happy. That is true for all these lenses. Other thing which is important is, which I didn't mention in the beginning also, all your patients who are doing multifocal IOL must do a OCT, macular OCT for your patients as a pre-op baseline, and subsequently a post-op period, if not first day, at 1 month, 3 months, you can do a macular OCT for your patients. Because if something has to happen to macula, normally happens after 4 to 6 weeks. That's why if you look into my treatment profile, I would normally give a steroid for 4 to 6 weeks for these patients. And I would start NSAID, especially a ketorolac type of drugs or an epiphenetic drugs for the next 8 weeks, so that I cover this critical period of macular edema happening in these patients. And once you have a little of macular changes, these multifocal lenses would be the patient will be having a much more difficulty than monofocal lenses. So treatment has to focus on that area. Second important area is ocular surface, which I discussed earlier also. Here also you have to look for ocular surface deformities, TFL instability, and accordingly treat your patients. That is what I'm coming on to a patient's satisfaction questionnaire, which is mandatory for all IOL surgeries, much more for these lenses where the patient is going to have much more symptoms. So we are looking for visually disturbing symptoms. Those are normally glare, halos, night vision disturbances like difficulty in driving or seeing multiple colors, or a starburst phenomena with the street lights, or a light coming from across the other from the vehicles, can be very, very disturbing sometimes. This is seen in the monofocal lenses also, but much more with the multifocal lenses as such. So they can be graded in a different scoring system, 0 to 5, and accordingly you can grade them. Subsequently, you can see the lifestyle activities, difficulty in watching TV. In that, especially you look for reading the caption which comes in the TV in the lower bottom of a television screen, and that can also be scored. Then look for a near intermediate distance acuity, how much spectacle independence they have. That percentage of time can be also calculated, and ultimately patient satisfaction scores can be graded from 1 to 10. So if you have a patient who scores more than 7.5 is a satisfied patient. If patient is scored more than 8, that's a really satisfied patient for you. Then two important things are there in the multifocal IOLs. The one I talked about, blurred vision. Subsequently, they are not seeing clear, which can be for distance, which can be for near, intermediate, or it can be for all three distances also. And second, we discussed the photopic phenomena. And etiology, as I said, residual refractive error, especially a cylinder for your patient, dry eyes or tear film problems. And in the long run, it can be a posterior capsule opacification. Sometimes you do have a lot of stretch line in the posterior capsule. That can also be a hampering fact for these group of patients with multifocal IOLs. In terms of photopic phenomena, I think most patients get used to whatever they see after IOL surgery. But there are two types of photopic symptoms which can happen. Dysphotopsia, one can be positive, one can be negative. And if you have a positive one, patient get used to this phenomena within a few weeks because of adaptation. While negative photopsia is sometimes can be very difficult because sometimes it doesn't go off. How do we differentiate between the two? But just by one test, just a pupil size. If you decrease the pupil size, the negative photopsia increases. So that is the patient's difficulty. If you dilate the pupil, the negative photopsia decreases while the positive one increases. So that has to be looked into. And patient normally in these multifocal IOLs, if they have a combination of all these, then they have a very difficult time as such. So if you have blurred vision here, if you see our chart here, the patient has a residual refractive error, then either you can give a spectacle for your patient, which normally patient would accept if you do a good counseling. But if patient doesn't accept this, then you have a refractive procedure to be done here. You can do a surface ablation, you can do a PRK, topo-guided PRK of your patients. In fact, one of the most effective method of correcting little bit of residual error is laser refractive vision correction for these patients. But if patient doesn't have a emotropia, residual refractive error, that means the lens may not be centered properly. As I said, there are two things: one, the diffractive design, and you have an aspheric design. Both cannot tolerate too much of shift. So that has to be checked. If decentration there, try to recenter the lens. If this also doesn't solve the problem, then patient does have a IOL which is creating problem. The IOL may require exchange for such cases. So you have to exchange only when the patient cannot tolerate the visual symptoms for a longer period. Similarly, if you have a photooptic symptoms, again, that can be divided into a pupil size wise. If you, as I said, if you have a cycloplasia bromidine, that can take care of your positive dysphotopsias. IOL decentration can also induce photooptic symptoms that can be treated by shifting the IOL centration wise, or it can be placed little anteriorly. It has been seen that if you are distant from the IOL surface and the posterior iris surface is much more, that means your posterior chamber is much deeper, patients tend to have a more negative photopsia. So that can be corrected by shifting the IOL by getting anterior capsular capture, and that is going to solve problem for most patients. Unhappy patients, you have to make them happy by counseling them more often, and ultimately they'll say, doctor, whatever you say, I accept it. So you have to more vigorously counseling them in these group of patients. But yes, sometimes they do have their own sets of questions that should be answered patiently, and make sure the patient realizes that you understand the problems. Therefore, I would say a surgeon first should imagine all the problems his patient is going to face before doing a surgery. Think how halo is going to affect you. So put glasses which is little blur, see how you see. So those things will give you an idea how patient will be seeing, how patient will be perceiving, what all psychosocial problem will be facing if patient has these problems. If I can't drive myself after an IOL surgery, and that will disrupt my total working time, and that is not desirable. The patient is genuine in terms of complaining, so we have to solve those problems. If you have one eye surgery done and that patient is not very happy, don't say that I want to do a second surgery so that both eyes are balanced and you have less problems. That might compound your problem multifolds. So first, I will manage this eye first, never do an early surgery for second eye. I know that there are many surgeons who prefer doing a bilateral simultaneous surgery also, and some people do early within the first week of other eye surgery. And the concept of neuroadaptation is placed in front of patient. You have to adapt, you have to adapt, you have to adapt. But you have to see your patient physically and look for optically what problem patient is facing, then correct those situations. So briefly, I'll talk about our experiences because we are talking about extended range of vision. And this is a study which has been accepted for a presentation this time in American Academy in Chicago. We had 50 eyes or 25 patients completing 1 year follow-ups after implantation of Symphony IOLs. As I talked about in the beginning, in all cases, we have aimed for a first myopia in these patients, and that is near emotropia for both the eyes. We didn't look for a mini micro vision for these patients. And these are profile of patients we looked into. Apart from visual acuity, we had assessed their wavefront analysis for all patients. We looked for the quality of vision because that is what we are looking for, not the visual acuity. We also look for quality of vision for your patients and quality of life. Therefore, the primary outcome was visual acuity. Secondary was quality of vision and patient satisfaction with these patients. As usual, 60 years was our patient mean age. Male, female was more males were in our study. If you were distant vision, we had a very nice visual acuity, almost 6.6 in all patients at day 1. And that persisted till 1 year also. And both intermediate and near vision was really good for all series of patients. So we had a very satisfied patient in all categories. The one thing I talked about was the improving contrast for your patient with multifocal IOLs. With these extended range of visions, because of the elongated focus, we did have a MTF, which is directly can be translated to a contrast sensitive for your patients, and a very nice MTF for these patients. If you look into this, is one of our patient, an eye trace of this patient. At a 5 cycle, you can see here, MTF was almost 8, 8.5, which is as good as normal patient. And the corneal and the internal total MTF values are also really fantastically good for this patient. But our average was, in this patient was also quite good. 0.44 is in a higher side than any other monofocal or multifocal or trifocal lens. Second, we look for our point spread function that looks into the quality of vision for these patients. And there also, if you look into a quality of vision, you can see how sharp is the focus for our patient. This is the corneal focus, this is internal focus, very sharp focus. So both the MTF and the point spread function was very good for this patient. Higher order aberration also, there you can see a very limited, no induction of higher order aberration for these lenses. So these three things contributed into a quality of vision with these extended range of vision. Independence for our spectacle distance, we had 92% of time, intermediate 98%, and near 95%. Anything over 90% for all three distances is remarkable result for any IOLs, and this is what we got from this particular intraocular lens. Glare, halos, dysmorphic phenomena were less than 10%, which is acceptable for any IOLs, and we didn't have any cases. We had a severe dysphotoptic symptoms for requiring any other intervention is in this study a group of patients. Glare and halos decreased subsequently in 3 months. So this proved that as time passes, these symptoms go down for all IOLs and holds true for this IOL also. Mean patient satisfaction score was 8.8 plus minus 1.2, which is a very highly satisfied patient quality-wise in terms of this thing. Stereopsis, we look for a distance near stereopsis, intermediate also. If you look into a 20 arc was achieved in 92% of cases, which is very good for near. And distance, we have a 60 arc was achieved in 84% of cases. And this is what we're going to talk about in American Academy. I think this is one of the first study looking on a stereo acuity of our patient with multifocal IOLs and ERV lenses. And if you look into our results, they had a similar results across the world. People have published on our Symphony IOLs. They also have a similar outcome for your patients. And the results in terms of vision-wise comparable to trifocals, but quality-wise they are far better than any other IOLs as such. So successful visual restoration across all distances, that is important, and minimal disturbing phenomena for these patients. These are few of our cases. If you look into teacher, I think he requires all the distance good vision because he'll be writing the blackboard, he'll be reading, and he'll be seeing the students. So he requires a good and ERV lenses here. Gave us a nice results here. Same for a housewife. Is a multitasking person there. They also do a multiple thing at a time. They are the people best suited for these type of lenses with the extended range of vision because they'll be doing so many things at a time and require a good vision as such. The success of Primo IOLs, if I summarize here, we have seen that proper selection of patients based on your pre-op investigations, patient demand, your investigation including all wavefront analysis and counseling will give you a best suited patient. I'm adding counseling because you may have a perfect patient for a multifocal IOL, but mentally he may not be up to that. The counseling will make the things perfect for your patient. And second important thing is always look a multifocal IOL that is not going to suit for every patient. Don't try to impose your multifocality of your thinking into a multifocality of patient eye. Not every patient is multifocal. Look for what is the demand and accordingly you choose your IOLs. And this word goes since the multifocals that were there since 1980. Everybody says under promise, over deliver. This is what we want to achieve from all of us. We tell them less, but we always give them much more. And giving much more is always better for all of us. And always look for a post-op for your patients. There can be various issues. You can have a high IOP, which is called little bit of epithelial edema, and patient has so many symptoms, which may be because of retained viscoelastic, because of many other things. Even a small thing, epithelial punctate keratopathy will be there because you're bombarded with a lot of drops. and you have a mentosa, and that can create a lot of problem for your patient. The post-op examination is very important for your patients, and always look for ocular surface and macula, as I said in the beginning, residual refractive error and patient psyche, and towards the end look for a posterior capsule. Because whenever a post-op patient comes to another surgeon, if I see a patient operated by Dr. Rajesh, next day I'll say patient has a PCO. Because posterior capsule is never clean, it's never clear. So next surgeon always says, oh, you have a posterior capsular haze, you require a yak capsulotomy. So that should not be the answer. Answer should be lying in some other area. Look for ocular surface first. Look for a punctate keratopathy. Look for a macula first. Then blend the posterior capsule towards the end. When everything is normal, then think of posterior capsule. Because sometimes these patients may require exchange of IOL after a capsulotomy also. Then the exchange of IOL becomes so difficult if you have open posterior capsule in your patients. The present day scenario, I would say we are moving from monofocal to multifocality in terms of a patient expectation and or desire as a surgeon to give them that. And I understand trifocal and extended range of vision IOLs would be there in future. And both have to modify subsequently to improve to 100%. At this moment of time, looking into literature and or study profile, extended range of vision IOL seems to be a good option for patients which can provide 20-20-20 for our patients. And patient selection, counseling, the key. I hope these few points will really make your practice for multifocal IOL very happy for yourself and your patients. Thank you for kind listening.
Thank you so much, sir. It was the whole story of multifocal intraocular lenses that was unfolded, and fortunately it's been an era when we've seen the evolution of all the multifocal IOLs, including the extended range of vision IOLs. So there are questions which we would like to take. Dr. Sonal Vyas wants to know if we use, can we use multifocal IOLs in well-controlled diabetic patients where no diabetic retinopathy is seen?
I think this is a debatable answer can be there. If you have a patient who's a young patient and going to have a life, very, very long life, they're bound to have a diabetic maculopathy or diabetic changes subsequently. Because duration is important for a diabetic changes to come up. But if you have an older patient, I might consider putting multifocal eye because his life expectancy may not be that much. And the duration of diabetes has to look into as such. Because all these patients would definitely require subsequent procedures. As I said in my talk, if you have a macular problems, the patient's visual quality will go down so much, they'll never be happy. So I'll be very careful. Maybe the age of patient and duration of diabetes is important for these group of patients.
So we have one query from Dr. Sanjay, who is from Pune, and he wants to know whether extended range IOL fitted patient read normal size book prints without reading glasses?
I think very nice question, because as I said in the beginning, we require a patient who can have a good vision in all distances. As far as my experience concerned, most of our patients could read book letters very clearly, because they are if you look in the font size of book letters, they range from 8 to 12 font size, and they can be easily read. And book-wise, if you look at various books, the contrast is quite good. Unlike the newspaper, the contrast is very poor. So book reading is very comfortable with the extended range of visions. That is what we have seen.
So there is another question by Dr. Nishant, who wants to know that if a patient has monofocal intraocular lens in one eye, can we go for symphony in the fellow eye? I think this is something which everybody asks.
I think, that all depends on the patient. So you put a monofocal lens in a patient, that means patient desires freedom from near vision. So you have a few options there. So you have an option of monovision in that patient. Put a monofocal lens, make that monofocal lens for near. Maybe you can go -1 to -1.5, that can solve. But there are situations patient cannot tolerate monovision at all. So you have to check that with a contact lens or giving a glasses and see how patient does in that type of solution. But I would understand because of extended range of vision where 92% light is transmitted and the distance acuity is as good as monofocal lenses. So I might try extended range of vision for these patients if they desire a good multifocality for this thing. Otherwise, if I look for other lenses which doesn't give you that amount of a light transmission, the patient would have such a contrast difference in two eyes, the patient will never be happy with the multifocal or trifocal as such.
Sir, I have a personal query. Like, we all use multifocal IOS and there are so many issues related to it. And one major issue that you highlighted was high angle alpha. Now, does these ERV lenses, do they help because of the larger central ring size in a borderline angle alpha? Whether you would like to, go ahead with that, or I mean, it's a query which many times, a difficult scenario which we face.
It is true, Rajesh, because we know that if you look into the practice which you follow across the country, most of the time we don't do these investigations for your patients. But yes, if you are doing these type of lenses, you may have to do it. As I said in my presentation, if it is more than 0.5 millimeter, then you may not be going for that. But if I look my own personal experience with angle alpha and the physiological decentration happening in all patients, not only for a symphony range of IOLs, for other IOLs also. But surprisingly, we have patients more than 500 where the results have been quite good. So either these lenses have a tolerance to the angle alpha also, or actually the measurement has to be different, because angle alpha and lens centration may not be the true decentration in these cases. So physically you have to dilate the eyes, take a photograph, measure the limbus to limbus, and measure the IOL center and the center, and that will actually give you a decentration. So those patients will be definitely poorer if they have more than 500 degree shift. But angle alpha wise, we have seen patients doing quite all right, but I'm pretty sure symphony range of vision, because they have a diffuse or elongated focus, might do well in this category also.
So there's a difficult question, and this is...
Well, any question is difficult.
Dr. Pushpa from Mumbai wants to know which is the best multifocal IOL.
I think the answer has been given during my presentation. A best multifocal is a lens which gives a best profile to your patient. Whatever lens you fit to your patient, if the patient is happy, that's the best IOL for that particular patient. As a surgeon, I will always look for providing best quality of vision for patients. So if I look for quality, I look for the lens which gives you a best transmission of light, that means best contrast and best distance acuity, two things. And then secondary will be my near intermediate. So if I have a best distance acuity, the near intermediate also improves. So I would say at this juncture of time, because I don't have experience with other trifocal lenses which are going to come in future, I would say extended range of vision will be the best choice for lenses for multifocality at this stage of time.
The next question is, which is the best instrument for IOL power calculation?
I think the question is basically the biometry part of this thing. I covered that in my talk also. Optical biometer with OCT attachment will be the best instrument to give you a best excellent measurement in these cases, and it also gives a best topography of your cases, and that will be the best instrumentation. But next to that will be if you don't have access to optical biometry, you can have an immersion biometry that also gives a quite accurate excellent measurement. And if you have system, as I talked about, if you have a intraoperative aerometer, that can you can say enhance your biometry or IOL power calculation on table also. So you have all the ranges available, but looking to one instrument, I think optical biometers will be the best one.
So there's one query from Dr. Sanjay Gupta. He wants to know what will be the result of when you mix and match with ERV lens in one eye and multifocal in the other eye, multifocal with +3 ad or +4 ad in the other eye.
Sanjeev, that's a very good question from your side also. I have not done personally, but concept is there. Especially if I put a ERV lens in one eye and patient, one question or they're reading books and patient not happy with reading books, it can happen. They may be a little cylinder, they may think. So I might go for Technics +4 in that, because that is going to give you a very nice reading and have an advantage of both the worlds. But before that, adequate counseling to the patient is required, because never know how these patients going to behave subsequently with the implantation. And that is the option there. And that all depends what type of profession, what type of work patient is going with. If the patient is doing more of office work, has a computer at a distance, intermediate distance, I might go with extended range of vision only in those cases, making little micro vision in that case.
So Dr. Chintan Gandhi wants to know that which is the best multifocal intraocular lens in the Indian category.
I think, as far as I'm concerned, I'm not really, experienced with Indian multifocals, but I'm very happy that many Indian companies have come forward with good designs. Good design means they have worked out themselves for last 5-10 years to improve their designs, their quality, and we have used some of them. But I hope that any lens which can give a little extended range of vision, and Appaswamy had come out with their what is it? Acufocus, in-focus lens, which also has an extensive depth of focus. So these lenses which have no rings and have a depth of focus would be the best lenses. The problem here is if you just look into an increase in depth of focus only, sometimes the multifocality doesn't come. So that is issues. We have to really look for which lens is going to be better. But in Indian scenario, there are two things. One is the patient's pocket, how much financial support patient has. Accordingly, people choose lenses. Given an option to me, I would have a single door for all the IOL. They should come in one category. You have toric, you have multifocal, you have trifocal, monofocal. There's one portal, single price for them. Then I can judge which is the best IOL, because finances change the best IOLs here.
So there are 3-4 questions which point out to the same thing. And like if you have if you have a multifocal in one eye from any other company, Indian or imported, can you put Symphony in the fellow eye?
Yeah, that is easily can be done. And the problem would be, subsequently after we put Symphony, then patient would demand exchange for other IOL also. But yes, given an option, as a theoretical wise, you should never have a mix and match. As far as I'm concerned, I should go with the same type of lens, because patient would have similar type of quality of vision, and would be easy for us to handle that patient subsequently. If I have a patient with multifocal one eye, I put a monofocal in the other eye, the contrast will be so much, the patient will never be happy. They'll say, why did I get multifocal in this eye? They'll demand exchange of lens.
So another question again points out to the same thing.
Yeah.
Monofocal in one eye, can we put Symphony in the other eye? So that answers all the questions.
Yeah, that answers, yeah. There I think we can think of Symphony, because patient would have advantage near and intermediate there.
Again, related to the indications, there are 2 questions. Can we put multifocal in pseudo-exfoliation patients? And can we put multifocals or Symphony IOLs in children?
These are 2 questions again a similar base. Pseudo-exfoliation, people would put multifocals. Depends how severe is the pseudo-exfoliation in these patients. And if I look into my category of patient, I would normally I do put a prophylactic CTR for these patients to have a uniform stretch onto a bag. So if your journals are getting weaker, at least it will not get stretched to one side, because one side journals can get weaker fast. The entire fibrosis shift the entire capsule back to one side, and you have much more chances of dislocation in these patients. But given an option, I would definitely avoid these lenses, because the chances of lens getting subluxated or dislocated, pseudophacos, would be very high in next 5 to 10 years. So we have almost incidence of a 10 to 20% cases, where you have to remove the entire bag and refix the lens. The multifocality, if patient is 70, 80-year-old, I might put, but patient is 40, 50, though pseudo-explosion may not be there at 40 years, but I'll be a little careful.
So Dr. Sharat Chandra Bhardwaj wants to know whether multifocal IOLs can be used for unilateral cataracts.
I think unilateral, yes. In terms of extended range of vision, I might say yes. Otherwise, I'll always go for monofocal lenses. Because other multifocal, the contrast is very poor. It's almost 60 to 50% down. If I see the MTF of my multifocal patient, they don't reach up to 10 also, if you look at 5 cycles. That is a very poor outcome for these patients. I would rather go for a monofocal lenses there, give them a near glasses subsequently. And as far as pediatric cases are concerned, it's a very debatable issue. If the pediatric patient is more than 10, 15-year-old, because less than 16 we'll consider pediatric, maybe yes, if this lens can be given. But if a child is less than 6 years, I'll be very careful to not to put IOLs, multifocal IOLs in these patients.
Dr. Nishant wants to know what is the comparison of Symphony and Technis multifocal in terms of night driving.
I think personally I have not done the study in that group, but they have compared the Technis with the Symphony. But Technis multifocal with Symphony, I'm not sure. But considering the Technis which comes from a +4, 3.25 to 2.75, and they have a various ring, Technis 4 is a full design refractive lens, so bound to have a more glare and halos compared to Symphony, and definitely they'll have a poorer outcome compared to Symphony IOLs as such.
There's a question from Dr. Meher, who wants to know, in your experience, what's the average uncorrected near vision post-operatively with Symphony IOL, whether it's N8, N10, N6, and what range you normally see?
If you look into our study where we had 100 eyes, the range is from N6 to N9, and majority will be within of N8 to N6. And surprisingly, in all group of cases, we had a very nice near vision patients, compared to other studies where near vision is slightly poorer with the extended range of vision. And I thought we analyzed how it has happened, because we always targeted little to the biopic side. So all patients we have from a -0.1 to 0.3. So that is what we have seen. All near vision has been quite good in our series of patients, and bilateral. So that is an advantage. And we had I don't think we had any patient who were less than N12 in our series.
So there's a question from Dr. Sarvana. He wants to know what's the effectiveness of accommodating IOLs.
I think today's scenario, there's no accommodation for us also, because the lenses have come in the past and they all failed in terms of accommodating powers. But there are a lot of research going on different types of IOLs. And in terms of if we have a good accommodative lenses, that would be the best for without photooptic symptoms, would be the best lens in future. But sorry to say, at this moment we don't have a.
We cannot accommodate it in our own practice.
There's a question by Dr. Ritika: is Symphony suitable for post-LASIK patients? And here I may just mention, a lot of our students are watching this, right, from Ritika, Mukesh Patil, and Vishal Arora, and
that's great,
all of them are watching you, your presentation and your answering of the queries. So, is Symphony suitable for post-LASIK patients, sir, and can we implant it in one-night patients?
I think in the beginning I had one slide on our post-refractive surgery patients. We know that the lens suited for these patients can be have so many options based on an entire corneal profile. So if you have a patient who had undergone refractive surgery, you have to assess the corneal profile of that patient. Accordingly, choose your lens. If patient is totally aberrated, which is bound to happen in a post-LASIK or post-RK patient, then any lens may not be suitable in those cases. I might go for a spherical lens in those cases. And if you have a good optics of a cornea, then Symphony would be the best, because, as I said, amongst the multifocals, the best transmission of a light and best visual outcome, Symphony may be a choice for these patients. As for one-eyed patients are concerned, again, there's no added disadvantage of putting multifocality there. But if the aberration profile is normal, I would put a multifocal in those cases also.
Dr. Balda has congratulated you and has commented that it's a nice webinar and it's very informative. Thanks a lot. So thanks to you. Like all of us, so many people who are thanking you for a wonderful webinar.
I think I should thank all of them for being there with us, because this is a topic which is for everybody. It is not for one group of people who are practicing. It is for everybody, right? From a student to a general ophthalmologist to everybody. We should be knowing what is cataract surgery and what should be our way of handling these patients. Even one query is solved from a one person's mind. That's the achievement for this webinar. And I'm really thankful to J&J AMO people and the AIOS to making this day for us, where we had a discussion on a common thing, but so many things are different than a routine practice.
So there are many more questions still left, and there's one query that whether we can use multifocals in that has been answered. Traumatic cataract in glaucoma patients who have undergone TRAB, and Yes, LASIK.
I think the glaucoma people I like to answer first, because these people who are undergone TRAV, they have their cornea never stable. Their astigmatism profile will keep on changing with the time passes, and as such, these patients would have a poor contrast because their optic nerve will be affected. Because TRAV is normally done in India as a secondary procedure when all the medical treatment fails. So these patients are not a suitable case for multifocal as such. So they would rather do better with the monofocal lenses. Maybe I'll go for toric lenses if you have a significant toricity as such, and should avoid multifocal lenses in advanced glaucoma, including TRAV patients also. In post-traumatic cataracts, if I can have a good bag where lens can be placed in the bag, yes, we should put lenses, especially patient because these patients will be monofocal uniocular cataracts because of trauma. But extended range of vision can be a choice for these patients because other eye will have all the ranges. So only extended range of vision can match the normal human optics at this stage.
Then we have a query: can we differentiate non-dominant and dominating eye? That you have already discussed.
That is
Dr. Rajiv Gupta from
can
Titiyal.
easily be done, and that should be done for as I said.
There are two tricky questions, and they are referring to you only. Dr. Mohak Shah wants to know which IOL you would choose for your own cataract surgery. Normal.
No, I'll definitely leave it to my surgeon to counsel me first, when and give me he'll be knowing my profile, the type of profession I am in. So he should be the person to tell me which IOL he will put in my eye. After proper counseling and knowing the result, then I'll say yes. But at this moment, given our time, which is the scenario which we are in at this stage, because as I said, 90-95% of lenses are monofocal lenses in practice world over, and that means monofocal lenses have an edge there. But looking into a profile of a person, if I get my surgery after 65, maybe I go for a ERV lens. Because that time I require a little better range of vision. At this time, my range is single. I want to see the distance clear, so that I can see my students far off across the India also.
So, sir, there's another question. In your practice, what is your percentage of multifocal IOLs versus monofocal IOLs, and that includes the extended range of vision lenses?
Yeah, if I see, I can grade my practice for a 5 years. If I look into 2015 to 18, 2010 to 15, and 2005 to 10. So 2005 to 10, my multifocal was one in maybe 1 in 70, and my torics were 1 in 70 again. But 2010 to 2015, this is a segment where we had all better scenario for IOL categories. So my toric lenses shifted from 1% to almost 15%, which is quite a large segment. My multifocal shifted from 1% to 7%. Now in 2015 to 18, my multifocals have gone down to almost 1 to 2%, while my extended range of vision has increased from 0% to almost 4%, which is a significant change. My torics have remained 14 to 15%.
So
I think this is a scenario in most people who are doing a good number of cataract surgeries. As I said, still we go the monofocal lenses. But I know there are surgeons who have, who only practice multifocal lenses also.
So there's a question by Dr. Madhav, and he says he's done one Zeiss multifocal IOL. In case the Zeiss multifocal IOL was implanted, and after 6 months, the patient needs correction of plus 2.5 diopters. So any reason why the patient could not, reach up to a distance vision by 6
Distance 6.6, but near patient still requires a 2.5. So this is a scenario sometimes we do face in our patient where we put multifocal or extended range of vision, because again the adaptation to a new focus is also important sometimes. Sometimes if you look at diffractive designs where you have near distance foci in each segment, so sometimes you keep on seeing for distance for near also, and patient can never adapt to a near focus. So that is a major problem, and the defocus blur will be so much for near the patient cannot see. And there I would understand significant residual refractive error or a cylinder will be the compounding factor for this patient. So these patients and such patient, the practice is, if you have a patient day one, patient not seeing near very nicely, don't try to give a near ad immediately. Let the patient be given an opportunity to see for a near from the multifocal lens. As time passes, patient might conceive and see the near. If you give a near correction to begin with, the patient will never see near. Then 6 months, 1 year is just for waiting for nothing.
So there's a very unique comment from Dr. Narendra Taneja, and he has congratulated you, and he says that you are looking like Subhash Chandra Bose, and he has said Happy Independence Day. So it's a Happy Independence Day to you also, Dr. Taneja, from all of us, and Dr. Titiyal would like to say something on that.
No, Taneja, thank you for your compliments.
First on your looks and then...
I never said, आप खून दो मैं देश को आजादी दूंगा. मैं तो I'll just say कि आप जो है give a best vision to your patient. I'll be very happy. And looking on to the scenario, looking for scenario of our country, like we have had our independence for so many years, and that holds true for our cataract surgery also. At least we have done so wonderfully well in a cataract surgery segment in last so many years, especially in last 2 decades. We have outperformed the thinking of our administrators in terms of providing a good quality cataract surgery across the country, and that is true for a happy moment for us as a teacher, that teachers could produce teachers to provide such a good facilities across the country.
I guess you should make a comment that tum cataract patient do main vision dunga.
That I have enough load. They have to now take away the load from me also.
Sir, I think this is the last question, and it is a little pertinent. It says if there are any specific guidelines for doing YAG capsulotomy in multifocal posterior capsular opacification.
I think a very, very nice question, because as I said, the posterior capsule is a major culprit for a cataract surgery. And as saying goes, you struggle so hard. Students sitting here, they've been taught, preserve your posterior capsule during your surgery. And ultimately, after cataract comes out, you have to sacrifice that posterior capsule. So sacrificing can be a good sometimes, because in Indian mythology, we sacrifice so many things to please our god and goddesses. The same thing holds true for the IOL and vision. To get our best outcome, you have to sacrifice something, and that seems to be a posterior capsule only. The criteria for a multifocal is, don't make a very small opening, because that's not going to work out. Because smaller optical opening is not going to give you a multifocality. That's one important point. If your pupil, which is less than 2 or 1.5 millimeter, nothing works. It's only for distance lens, because most lenses will have a central distance. Similarly, if you have an opening just 1.5 millimeter, that's not going to work out for your multifocal patient. So openings should be at least 3.5 millimeter in such cases, so that your multifocality comes into action. But that should suffice in your patient. Make sure you just hit the posterior capsule. Don't damage your diffractive rings, because they are all in the posterior side. And once you damage that, they're going to have more problems. Similarly, don't disrupt the vitreous. So once do a YAG capsulotomy, just assess your posterior segment again. And before doing YAG capsulotomy, must assess your macula, rule out a macular pathology, then do YAG capsulotomy in your patients.
Thank you, sir, for those great tips. And I think multifocal IOLs is such a tough subject to understand. It comes out of as huge an experience as you have with all kinds of patients, including great VVIPs that you operate. And we would like to thank you for this excellent presentation, and for being with us and sparing your valuable time with us here today. And we would also like to thank the RP Center team, the AIOS headquarter team, and the J&J Johnson & Johnson, Mr. Jaswinder, for holding this first international webinar. There were a couple of comments which were in a language that we couldn't understand, because they're coming from some other countries, but we hope to find a solution to that too also. And we would like to felicitate you from our side, sir.
Thank you. Thank you.
Thank you, sir.
Thank you, sir.
Thank you very much. We had a nice discussion. The questions are very interesting.
The
Very
questions
nice.
are very interesting. They are questions which are so often asked, but answers are as ambiguous. But I think you clarified it all, which is the best part. And coming from your mouth or from your this thing, it really adds a lot of authenticity to
there
it.
are some more questions which are repetitions, so we didn't ask that. But,
thank you so
it
much.
was a wonderful.
Thank you.
Thank you. I think we should thank the audience also.
Should thank the students here. If you can just put the camera on that side for sparing their time coming here, and all residents of RP Center. Thank you again for coming here. Thank you.